So within this is let me tell you, let me say it right.
Okay.
This is the first summit case.
First summit case.
In Florida.
Okay.
It is not the first Tendyne. Tendyne is the device that we use. It's not the first Tendyne case because the other hospital did the first. They were in the early trial. There was the feasibility study, which was the early trial before the summit trial.
Okay.
And they were part of it. We were not. So they did the first case in Florida. So we were not. In the summit trial, which is the large multi-center trial of using transcatheter valve replacement with a specific valve for the mitral valve, which is the Tendyne device.
Okay.
How do you spell that?
So, Tendyne, Tendy, Tendyne, Tendyne with DY, N-E, Tendyne.
Okay.
Tendyne.
Okay.
So anyway, it's Abbott, okay? We have a research. If you ask Maria Ardin, she has everything about it, or Herrera, they can give you all the info regarding to the trial specifics if you need that.
Okay.
And the device and how do we divide it. It is multiple pictures of how do we put it in. It's a big endeavor. It's a true hybrid procedure. Because to replace the mitral valve, you can do it two ways. You can go up through the apex of the heart, or you can go through the septum. And off-label, we do it off-label with other devices. Like we use the valve that we put in the aortic position, the Edwards valve, and we go transeptally up to the septum and place it in the put it in the mitral valve. That is off-label, but that's what we have available to us, and that's what we do. We use it. Now, this is the first specifically designed valve for the mitral. The problem with the mitral valve is that you have to anchor the valve. So we can use the Edwards valve when you have anchors in the mitral, like if you have a lot of calcified mitral annulus, then we can use a valve for that. But when patients have severe mitral insufficiency or stenosis, and you don't have any calcium in the valve, then you can't, because you cannot anchor the valve. So this is a special design valve that you can use for those reasons. Now, if you have calcium in the valve, you also can use it. And as a matter of fact, what we call valve in MAC, when there's a lot of calcium in the valve, the early data 1 year suggests that this is the safest way to valve up to date. The mortality in 1 year was 0%. And the mortality of using the conventional way that we've been using off-label is 20%. Just to give you an example. Don't quote me on that, but also grows in the numbers. So it's a very active area of research, and this is the first trial using a specific valve for the mitral. Very important, because there's a lot of patients that will require, the anatomy doesn't allow me to clip it. So the study is randomized to surgery, one arm, to clip other arm, and then patients who don't qualify to clip or surgery, they can get the device without being randomized. You can get the specifics about the device, about the trial from the research people.
Yeah, I actually have it. I have it on the website.
So we've been actively screening. We have screened 40 patients, for example. This is the number of patients that we see, because we get a referral site for mitral, and we get a lot of referrals for mitral insufficiency. For X, Y, Z reason, we have to exclude these patients. We can't get it. And some patients, they don't want to hear the word research. That's something that is very, very difficult to convey to the patient. But this is a patient who we've been waiting actually for 4 to 6 months. It was approved in March. At the end of February or March. It was approved in March, and then the whole thing of the pandemic, we couldn't do it. So he's been patiently waiting until now. finally was successful, and beautiful procedure. Has no leak in the valve. It's perfect. In the valve area, you have the combination of mitral stenosis and mitral insufficiency, severe, the mitral insufficiency, moderate mitral stenosis, and we treat both. And the valve area is 3 millimeters, which is incredible. That's the largest size. It's almost normal. There's no leak.
Okay.
Now, it's a true hybrid procedure because we have to go through the apex. And we put a big tube in the apex of the heart, so we have to make a hole in the heart. So that's why it's hybrid. The surgeon, Dr. Moreno in this case, is the only surgeon that is part of the trial. Makes an incision in the apex, and he controls the catheter in the apex, and then we can advance all our instruments across the mitral valve. And once we have the wire in the left atrium across, then we advance the delivery catheter with the valve inside. And then it sounds easy, but you have more than that. We start deploying the valve under direct echo visualization. Echo is key here. So the imaging is a must. And I have to say that because we have an MCVI, one of the most advanced hybrid rooms, and we can have images on every side, we can, no matter we are located, positioned in the procedure, we have access to imaging. And that makes such an incredible difference to make everything go so smoothly. Actually, we take it for granted, but the people who came from the study said it's unbelievable. You guys you don't have to move your head. You're right there. You're seeing everything. And imaging is everything. If you can see it, you can do it.
Right.
So the whole process the procedure went very smoothly. And the beautiful thing is that the patient doesn't have to be placed on it's done obviously at the general anesthesia, but you don't have to put the patient on the heart-lung machine.
So no bypass.
That is what makes this a bypass machine. So that's what makes everything so minimally invasive.
Okay.
And the recovery time for these patients is very, very short compared to a conventional open heart mitral valve replacement. And more important, that the residual mitral insufficiency is zero in more than 90% of the cases. And you can control how much leak you're going to have because it's technical stuff. But depending upon the tension that you put in the valve when you are deploying. So this is the beginning of a new era in a structural heart that we're going to be able to use a specially designed valves for the mitral and in the future for the tricuspid, for that matter, and that will be able to provide this and give this to patients who otherwise are not a candidate. This particular patient was a very high risk because he already have an aortic valve replaced surgically, and he has multiple comorbidities, and but for this, he was perfect. So
all right.
I was very, very, very pleased and happy with the results, and I think we're going to continue screening more patients and enrolling more patients in this study.
Can I ask you,
if you put them in perspective, when we started the MitraClip studies, that was 2005, 2006.
Right.
It took 15 years of experience to approve them. So the fact that we are so early in the learning curve with these technologies make us as the center, our institution, ahead of the game, way ahead of the game. So if you wait until it's approved, you are at the end of the line, really. But if you are at the beginning of the learning process and being part of the innovation and the research, then by the time it is approved, you're really expert. We have so much experience. That's what happened with the MitraClip, for example. By the time it was approved, we already have 300 cases under our belt.
Okay.
You know.
So,
And we were experts on the field, and actually we went out. We teach. We're proctors, so we go and teach others, multiple sites to do it, and those sites are the ones who refer their cases to us when they're very complex.
so
The only way to maintain that the pipeline of innovation and make MCVA a quaternary center is that we are actively involved in clinical research and innovation. It really, that's the bottom line. That's the message, by the way.
okay, and you say early in the learning curve, but you've succeeded, at least, certainly with this procedure as a major.
Well, maybe I shouldn't say early in the learning curve. Early in the experience, because it's research.
Right. No, I mean, it's a major trial.
The center who has the largest experience in the United States has done less than 50.
Is it right? And this is the first one you've done this type of mitral valve.
That's right. This is the first time we've done. We had to do a lot of rehearsals and stuff. It's a lot of work.
Right.
And it was we did beautifully, thank God, and a very controlled environment. The whole team, everybody involved, will perform. It's like an orchestra, you have to perform.
That's right.
It was beautiful.
Now, is it right to say that they will look at these results in the future for approval here in the U.S., right? This is something that yes. The multi-center trial is looking for the approval of this device for clinical use. Yes. In the U.S. Okay, yeah.
In the U.S. And Europe is already approved.
Right, I see that. Yeah, and I'm looking at something online here from January of this year from Abbott.
You got approved, and they always get.
Yeah.
They're always ahead of us.
Yeah, I know.
They have less regulations. I think our process is a difficult process, but I think it's the right process.
Okay. Safety
for our patients is the number one concern, and not everything works as we expect it to work. So it's important that we learn this early enough so we can take the right directions if we need to make changes. So that's why I'm not criticizing our process.
Right, no, I
I'm
know.
just saying that our process takes longer, but because we're concerned with safety.
By the way, what was the age? What is the age of the patient, by the way? Do we know?
This patient was 70. You got me in the age. I'm unblocked, but we
70s?
can give all the information.
In the 70s? He's in the 70s?
Yes, we can give you all the information.
Okay.
The fact that he already perhaps prior open heart surgery put him at a higher risk.
Right.
We do a mitral valve now.
But he had a
that's why he qualified for this.
He had a TAVR done when? You said he had a...
No, he had an open heart...
TAVR.
Surgical aortic valve replacement.
Aortic valve replacement surgically, okay.
Yes, surgically.
And do you know how many years ago that was? Or?
5 years ago, more or less.
Wow, okay.
I don't know the exact data from the history.
And is that, how rare is it for someone to have aortic valve replaced and then, a mitral valve? And that's like...
You will be surprised.
Really? All right.
We see, and a lot of our patients are early patients that are complex. They have multiple valves. Some patients, they're so complex that they're so beyond our point of care that we just turn down a patient like this, but sicker. And we felt that the chances of survival, you need an aortic valve, mitral valve, and tricuspid valve.
Oh my God!
3 valves.
Oh.
And in a 70. No, actually this patient was younger, was 60 something, but she was a hemodialysis patient, severe coronary artery disease that was not surgical, so it was a mess. Every single, not only the kidneys, but the heart, all the valves, the coronaries, and it was so complex, so difficult that we just cannot do it. I think we do this patient. She would not survive. Not only that, because to get to the mitral valve, we have to create a space in the left ventricular outflow tract that sometimes we have to do is alcohol septal ablation to make the outflow tract bigger, which is giving her a heart attack, controlled heart attack.
Right.
It's complicated, super complicated.
Right.
So, we all decide, yes, we can do it, but this patient in particular, no, we're not going to do it. Why? Because, the chances of help them are minimal.
Right.
This
But this,
is the patient that we did, that we make a blog of the lady with cancer. But by the way, she's doing great. She's getting chemotherapy. She's happy.
oh, good.
And so whatsoever. But, we
Oh,
very
Dr.
complex cases.
Quesada, did you tell John that our friends at Memorial were not very happy about that?
They were very happy about it. They read it. I thought they were not going to read it, but everybody reads it. So they were very happy. The referring intervention academic called me and said, "Listen," he said, I saw your article. It was great, but the people here in Memorial are very unhappy about it."
I think it makes them look smart. They went to the best. They went to the best specialist, which is you. I mean, our team here. That's smart.
Yeah,
That's smart,
so
right?
The point is, so the interventional cardiologist who referred the patient the structure of this, he was honest. He
Yeah.
said, "You guys don't want to do it. You guys can't, feel not comfortable, but we need to help this patient. I'm going to find somebody who does it."
Yeah, I think.
And the guy, he called us, and we said, "Well, I talked to my team. I said, I think we can do it. I think we can help."
Seriously, I think it makes them look good.
Fortunately, everything worked. But,
Yeah.
that's what I'm saying. It puts you on a different level. So being part of all this new environment, new technology, new development, new things, it put us as an organization in a different perspective. Should this be done in every hospital? No, absolutely not.
Right.
Because you can't reproduce the data. This is not a technology that's going to be done in every single hospital in the U.S. I'll tell you that right now.
Oh, of course.
Why? Because it requires a lot. It requires a lot of dedication and infrastructure, and it will be limited. There's no question about it. And that we should learn from our colleagues in Europe. They limit. They have centers of excellence. That's why they do all these procedures.
Right.
And the other places refer the cases to an institution that's going to be doing all these complex cases.
Right. No, like I
My
said,
job,
yeah.
our job at the MCVI is we are and will be part of that story.
Right. Yeah, and your job is to save lives, no matter where they come from. referred from.
Our job is to save lives, but our job is to be in a center of excellence and be part of the innovation and technology.
And, yeah.
Offer this to all of our patients. But it doesn't mean that all the hospitals in our system we're going to be doing this. It doesn't apply to that. I think we learned something from our European colleagues that you have to not limit, but you have to select where you're going to be done, and you put all your efforts in that place, and you refer everything to that place so they can get the best results.
Right.
That's probably where we're going to. We're moving to in that direction.
Right. And I think I know the answer to this, but to say that in this case, this gentleman in his 70s, this was a life-saving procedure, right? I mean,
Absolutely.
Absolutely, yeah. Because his prognosis was very poor.
And the potential to listen. This is the first generation.
Yeah.
Actually, the second generation of the same device. Because we were trained in the first generation, and this is it is better. It simplifies a lot of steps, but still, there's a lot of room for improvement.
Right. Which the
most important thing is that they're going to have to miniaturize the system. So it can be smaller with less trauma to the heart and to the patient, and it will get there with time. Okay. But we just have to be patient, and we have to do continue doing our best.
Is there a good easy way of explaining why aortic valve replacement is so more advanced than mitral valve replacement? Is there a reason that consumer can
I'm going to give
understand?
you. I'm going to give you a simple way of thinking.
Okay.
You know, if you see it, the aortic valve is like an odometer of a car.
Mhm.
It's broken, you take it out, you put a new one. Right?
Right.
Simple. The mitral valve is like a cockpit of a 747. Very complicated, very complex.
That's perfect.
And the tricuspid valve is really, it was the forgotten valve until 4 or 5 years ago, 5 years ago or more. It was the forgotten valve. Everybody thought nobody cared about the tricuspid valve. When I was in medical school, they used to say, you can take the valve out, you're going to be. And we found out that no, you're not going to be fine.
Right.
But it's very insidious.
Okay.
And that's why it will kill you the same, but insidious.
Right.
But the complexity is totally different from it. The aortic valve is a simple thing compared to the mitral and tricuspid valve. That's why the mitral is a lot more complicated.
That's a
When
good.
the surgeons repair the valve surgically,
Mhm.
it's a beautiful operation. It's complex. And as a matter of fact, if the valve can be repaired surgically, in a young patient, that's the standard. That's the way to go. Now, it has to be by a great surgeon
Right.
with a lot of experience in mitral valve surgery. Why is that? Because if you look at the average, the majority of surgeons in the U.S. do less than 5 to 10 mitral valve surgeries a year. That is a fact. So the places when they do hundreds of them a year, they have incredible results. So it's a difference with the amount of experience that you have.
Right.
But we are not competing with surgery. This is not to compete with surgery. We already proved that. When we were doing the Everest trial with the mitral clip, the first trial was all comers, low risk, whatever. We thought that we were going to be better than the surgeons. And no, it proved us wrong. The most beautiful operation for mitral valve repair is surgically. Now, in the patients who are at high risk for surgery, that you expect a mortality that is going to be higher, those patients did better with mitral clip. Not only they did better, we proved mitral clip was superior.
Right.
And that's why it got approved for high risk patients. So when we select a patient for mitral clip, for mitral insufficiency, so our patients were high risk.
Right.
And that was for both. When we call it primary mitral insufficiency, which is the disease of the valve itself, or secondary mitral insufficiency when it's disease of the muscle and you have mitral insufficiency because the valve annulus gets very dilated. In high-risk patients, no question about it. Better than surgery.
Right.
And in functional MR, which is secondary MR, there is no surgery. The therapy of those patients is being always medically. That's why COAPT was a randomized trial, not against surgery. It was against medical therapy. And
Right.
it proved it was superior, mitral clip, and that's why it got approved. That's why mitral clip is approved for primary and secondary MR in patients who are high risk. But what about if the anatomy is very complex? And when the anatomy is very complex, mitral clip, even though I love mitral clip, we don't get the best results. So when the anatomy is complex,